I want to thank the ranking member, and I thank the chairman for calling this important hearing. I thank the witnesses for their testimony today and for your work on an extraordinarily important issue. This report outlines alarming lapses in coordination at the federal level. It raises questions about how federal funds are being spent and points a finger at our nation's patchwork mental health system for failing to meet the needs of millions of Americans. Back home, I see communities on the front lines of a growing crisis, looking for the federal government for support. From substance abuse to at-risk youth, our failure to deliver dependable, affordable, and accessible mental health care is costing lives back at home. So instead of throwing in the towel, we should see this report as a rallying cry. We must do better, devote more resources to mental illness, invest in our efforts at improving coordination, evaluation, and delivery of care. But for that to work, we need to know the scope of the problem and the range of our response. We must have the commitment of our federal partners to take on a growing problem. Lasting mental health reforms are long overdue, and I look forward to working with all of you. I want to thank again the chairman and ranking member for calling this important hearing.
That's right. Mr. Kennedy, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and I thank the witnesses again for their testimony. Just want to put the discussion today in context, which I think is an extraordinarily important discussion, and hopefully we can try to find some ways to work together on making sure that these programs are getting to an extraordinarily, a population that needs some extra assistance. But Dr. Frank, I think in the HHS response letter, they put into context that of federal government expenditures on mental health, Medicaid pays for about 27%. Medicare is about 13%, private insurance is about 26%, and all of the other programs that are subject to today's discussion are roughly 5%. Is that right?
Correct.
So the discussion that we're having here, as integral as it is to making sure the system works better, we're also talking about 5% of the overall mental health spending in this country. So if we're looking at a much more systemic approach, one would say we should also focus on the 95% of the rest of that funding and how to reform that delivery system and make sure that care is much enhanced. Is that fair to say?
Yes, I think that's exactly the point I was making, not to in any way diminish our need to pay attention to the 5%, but the other part, the other 40% really needs attention, and that's why our integration efforts on health homes, on duals, on expanding SNPs, on expanding case management are so important because they happen in that other part.
When I'm back home, doctor, I hear all the time about lack of beds, lack of availability of doctors, lack of wraparound services. It strikes me that a lot of that has to do with incentives and the way the federal government reimburses doctors, hospitals, clinicians that are working in this field. You align those incentives properly, you're gonna get the beds, the treatment facilities, the incentives for doctors to treat. Is that right? Fair to say?
I'm an economist and I believe that.
Okay, thank you. So with that as context, I do want to go back to the basis of the report for a quick minute. The report indicates, quote, that coordination specific to serious mental illness was lacking among interagency committees, end quote. But it goes on to say that, I believe, again, quote, staff from 90% of the programs targeted serious mental illness reported coordinating with their counterparts in other programs. The coordination we're talking about doesn't happen because it's legislated. It will only happen if there's, it will only be enhanced if there's a cultural change at some senior staff level and a willingness to implement both the letter and the spirit of the law. Dr. Frank, how can we engage senior staff, and does that interaction at the necessary, or at the staff level suffice, or is more senior staff interaction necessary? We'll start with you and go from there.
I think your point about culture is very important, and I think this administration has been extraordinarily attentive to building that culture. Administrator Hyde has had a central role in that, taking SAMHSA and reaching out far beyond their 5% there into Medicaid and to other areas. Our secretary is extraordinarily supportive of these matters, and so the result is we have tremendous amount of joint activities with HUD, with SSA, with labor, with Treasury, et cetera. And it's really those types of focused working groups across the government that has really, I think, improved our ability to coordinate in a variety of problem-specific areas.
Thank you, Doctor. I'll just stop you there because I got about a minute left. And Ms. Hyde, if you have a response to that.
I think I would just echo Dr. Frank. The recommendation that was made was about a specific type of infrastructure that we think isn't going to be the best way to address the issue on the ground. So that's the distinction we're trying to make here, that we have a lot of coordination going on. We believe in coordination, but the particular recommendation is in the approach seems just like more bureaucracy.
So if creating that or strengthening that interagency working group from a senior level isn't the right way, and understanding that you're pushing coordination now, I realize I've only got about 30 seconds, but what would you suggest in 30 seconds to really push that out to the lowest levels on the ground and try to enhance that coordination even more? So I think it's hard to debate the fact that that's needed.
I think it's multifaceted. We have to have person-to-person interactions. We have to have working groups on specific issues, as what we described. We have to have staff-to-staff level programmatic interactions, and we have to push our grant programs to require coordination at the state and grantee level. So we're doing all of those things and trying to bring that together where it works on the ground for individuals.
Thank you. I yield back my extra 7
You
seconds.
want Dr. Cohen to also answer your question, too, because she didn't get a chance to
Yeah,
answer that
if you
question.
don't mind. Thank you.
Dr. Cohen?
Please.
Okay, sure, thank you. I don't think what we're putting out here is an either-or, that if there is coordination at a local level, that therefore coordination at the federal level is unneeded, or vice versa. That coordination at the federal level will supplant the coordination that happens at the local level. I don't think it's that kind of a trade-off there. And the concerns we were raising about lack of coordination at the federal level inhibits our understanding of the federal footprint in this area. What are the programs in place, recognizing that there's a lot there in Medicare, Medicaid, and Social Security, as the OMB letter in response to this committee had shown. But we didn't start from that spending side. We started from the programs, the population served. As Dr. Frank noted, people don't fall into neat program categories. And that's why that coordination becomes so important. Because that coordination helps identify if there's any potential overlap or duplication. Are there gaps? Are there programs that are complementary that aren't being linked together, need some stronger linkages so we maximize our existing resources and our existing programs? If it's a gap and nobody's looking at it right now, then how does the coordination happen? It's by definition not visible. So the coordination we talk about is not instead of the coordination at the local level, it's in addition to.
Thank you. Thanks for the extra time.
Thank you.